Okay, so for the remainder of our event today, we're going to be joined by Terrell Hansen, who's a graphic artist, who will be live illustrating our program. So for those of you who are interested in following along visually, Terrell will be providing graphic illustration alongside our speaker talks. So some of our speakers will be using slides and some will not. And throughout, you can tune into Terrell's illustration by clicking on the participants option in your control panel, finding Frame the Message Ink, and then clicking on the three dots next to the name and then selecting Pin Video. And what Pin Video does is it allows you to keep that video kind of prioritized, that particular stream at the top of your list for videos that you're going to see. Right now I can see Terrell's because I know that Frame the Message Inc. Hi there is set up on mine as a co-host, so it's kind of bumps her up a little bit as well. So if you're interested in watching the live illustration, this will allow you to see the thumbnail of Terrell while she's illustrating while still watching the slides and seeing our speakers present. You can decide not to show any of those at any time so that you can kind of choose your own experience. Um, so any questions about that, feel free to put it in the chat box and we'll do our best to help you with that. And excited to have you along, Terrell. It's, you know, an interesting process shifting into these different mediums.
Thank you for having me.
So for the next hour and a half, we're going to be learning about trauma-informed practices from people who have significant experience with serving adolescents. And their full bios are on the event site, and I'm going to share their highlights right now, just as an overview. So Dr. Julie Blasek, she's an MD, a clinical lecturer and academic fellow in the Department of Family Medicine at the University of Michigan, and she completed her medical school and residency training at the University of Michigan and was co-chief resident. She's currently completing a Master's of Education in the Health Professions from Johns Hopkins University, and her interests include LGBTQ health, specifically transgender and non-binary care in the primary care setting, medical education, care of the underserved, and medical anthropology. She practices at the Michigan Medicine Chelsea Health Center, as well as at the Corner Health Center for Adolescents. So Kaylee introduced Amanda a few minutes ago, and we've been planning with Amanda for this session for a couple months. And she recently saw Jasmine Pettit, who's a colleague of hers at Outside In Portland. And Jasmine performed a piece about trauma at Telltale, which is a curated storytelling event to connect community during a time of collective trauma. So Amanda is sharing some of her time with Jasmine, who we're delighted could join us to perform one of her spoken word pieces. Both Amanda and Jasmine have decades of experience serving LGBTQ+ youth experiencing homelessness and chronic complex trauma. And then Dr. Alex Karolian directs the National LGBTQIA+ Health Education Center, a HRSA-funded cooperative agreement to improve care for LGBTQIA+ people at health centers, and he's the director of education and training programs at the Fenway Institute and associate professor of psychiatry at Harvard Medical School. Me going through the bios right now means that we can have a little more seamless experience when we're hearing from our speakers. And just again want to reiterate that we hope that the range of perspectives and practices will be useful to you both in the specific ways that you practice care with young people, as well as the ways that we navigate parallel process dynamics between community trauma, organizational trauma, and individual trauma. I appreciate also that Dr. Gibson kind of mentioned elements of this earlier in her talk, which I think will really weave in well with the ways that we think environmentally among teams and coworkers and our own individual ways of coping with working in and among people who've experienced trauma in our own experiences. Okay, so without further ado, I'm going to turn it over to Dr. Blasek.
Hi, everyone. Can you hear me? I just want to confirm before I get going.
Thank you. Yes, we can hear you well.
Great. Well, hi, everyone. Like Jenny said, my name is Julie Blazak. I'm from the Department of Family Medicine at the University of Michigan. And first, I just want to thank Adolescent Health Initiative for inviting me to speak on this important topic. I was telling Jenny last week that during my medical training, I didn't really get much training, formal training on trauma-informed care at all. So I'm just so happy this is highlighted. And I want to warn you ahead of time that I won't have any slides today. With all of the Zooming I'm sure we're all doing, I thought it might be refreshing to have somebody that doesn't necessarily have slides, and I thought it would highlight our illustrators. So I'm hoping that after my presentation that people will feel free to share in the chat if you have any experiences that you want to share at all, or if you want to speak up and unmute and ask questions, please do so as well. And so for the outline for this talk, really I'll be talking just very basics at first, and then I want to go into what to do before an exam, during an exam, and after an exam when we're thinking about trauma-informed care. And I want to give credit where credit is due. So I do have to say that this talk is really modified and created based off of the work of Megan Gerber and also Sadie Elisu over in Boston. And so I believe that Adolescent Health Initiative will send out some resources for you as well. But one that I do recommend, especially for those in the primary care setting, is Megan Gerber actually has a book from 2019 that focuses on trauma-informed health care in the primary care setting. And then actually, if anybody's a fan of the Curbsiders, the internal medicine podcast, she was actually recently on it in June of 2020 as well. And so I shared that with Jenny too. And so let's talk about trauma-informed physical exams. First, I'm sure as you heard from Dr. Gibson, really trauma-informed care is really a framework. And so it really involves recognizing, responding to all different kinds of trauma. And the principles and recommendations that you'll learn from this talk, I want you to know can be applied universally. And what I mean by that is often when we come into the exam room or the office, we aren't necessarily sure of the trauma that somebody has been under or the type of trauma they have been. Perhaps they're there for another concern, or perhaps they choose not to disclose. But we don't need to know someone's trauma history to really perform compassionate trauma-informed care. And so one of the major takeaways I want you to take from this talk is that you do not want to make assumptions about who or who has not experienced trauma, and also what parts of them have experienced trauma. And so with the physical exam, we want to provide comprehensive care, but we want to avoid re-traumatizing individuals as well. And as you know, there's already a power differential in the visit when you walk in as a provider. And so today, the big themes that you'll see over and over and over again, and if you completely tune me out except for these 5 seconds, just remember consent, 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 and explain, explain, explain. And this is really going to help give the patients some as much control and choice as possible within the visit. And I want you to know too, as a family medicine physician, I care for people from birth to end of life, and so this can really apply across the spectrum. But I will also try to throw in some pearls of wisdom that are specific to adolescents as well. So let's pretend again that you've already taken a history, or perhaps they've already talked to you about whether it's disclosing their trauma or not, perhaps they're there for something else, but that you have to do some sort of physical exam, or you recommend, I should say, doing some sort of physical exam. And so before you even get started, the first step is to set the stage. And so you really want to make sure to reflect on your own behaviors and really focus on your own nonverbals as well. So you want to speak clearly and slowly. I have a very hard time with that. I speak very fast and I tend to be very energetic. So being calm, speaking clearly. You want to be engaged. This is not really the opportune time to be typing while a patient is talking, or while you're trying to explain the exam, especially if they're disclosing something that's very personal to them. You want to be at eye level. You never want to be standing over a patient. You really want to avoid sudden movements. You want to have your hands outside of your pockets. You want to make sure to pay attention to the patient's nonverbals too. Are they acting jittery? Do they seem to be looking away from you? You want to make sure that the patient feels safe, so that they are sitting in a space that they feel that they could access the door if needed. We want to make sure that the lights are on, and if we do have to have a dim room, we explain why, or perhaps we have the door cracked open. These are all ways that we can set the stage in the exam room. And then next, once that physical stage has been set, we really want to set the agenda with the patient. And so this is going to be a common theme that I would recommend continuing a dialogue with the patient throughout the visit and throughout the exam. So what are we doing and why are we doing it specifically? So saying that, again, with all patients with cold-like symptoms, I recommend listening to the lungs. And then the next part of that is that okay with you? So explaining what you're doing and why And also making this standard, explaining why that I do this for all patients. It's not specific to you. This is very helpful with working with my transgender and non-binary patients as well, because as we all, I'm sure, know that population, so a lot of people tend to focus on their sexual identity and gender identity, even if they're there for, let's say, left arm pain. But if they do tell me a concern that I would have to do some sort of sensitive exam, I'm explaining why. So I'm explaining that, again, I care for all parts of your health, and this is why I'm doing this. And so when I ask, is that okay? You want to receive consent for all parts of the exam. So consent, 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 again, explain and get consent. And this, again, is to give the patient as much control and choice. I realize this too. I'm at fault that after I've done 10 or 15 exams for a day, I realize sometimes I pop up and I say, okay, let's take a look. And I put my stethoscope on somebody's chest. And you get into this rhythm, but really taking a breath and checking in with yourself and saying, wow, did I actually ask the patient if I could do this? Did I actually explain to them what I am doing? And then next, you want to ask about questions and concerns about the exam. So what could I do to make you more comfortable? Or is there anything that's been done in the past that a practitioner or provider that has done that's made a physical exam difficult? And this opens up the opportunity for them to share if needed. And then next, before we go into the actual exam too, I think this is an opportunity to talk about chaperones specifically. And I just want to mention with chaperones, I would encourage all of you in your states and your institutions to look up the different policies, because this can change depending on where you practice. I actually looked at Michigan Medicine's policy last night again, just to make sure there were no big changes. But for chaperones, there's really an opt-in option, which means that a patient asks for a chaperone, which they can do at any time for any kind of exam. Then there's opt-out, which is again at least what we term non-vulnerable adults. For sensitive exams, that's mostly what we do, that we recommend an exam, but they can opt out if they'd like to, and that's what's documented. And then next is mandatory, meaning that in order to do the exam, a chaperone has to be in place. And so at Michigan Medicine, specifically for adolescents, it is listed as mandatory. So they do say that during what they consider a sensitive procedure, and they have a list of what they consider to be sensitive, which again is, I'm sure, fairly common sense for most of us, but especially breast or genital exams. They say for all vulnerable, quote, vulnerable populations, and they do consider that people under the age of 18. And so they do say that that is mandatory at our institution. And so, of course, adolescents can dissent at any time. And then you may have to explain the risks and benefits of not doing the exam. We're not going to obviously re-traumatize anybody by saying that they have to do anything. I also just want to make a note that in Michigan Medicine policy, at least, it does say that a family member cannot act as chaperone, and I would not recommend that as well. And then also, a family member cannot opt out of a chaperone for the adolescent. And I want you to be mindful when you think about who is chaperoning. We already talked about the power differential there. And for instance, at our institution, students can act as chaperones if they've undergone training, but I actually would not recommend that. We think about chaperones a lot as providers protecting us, which of course there is a part of that there, but really chaperones should be there in order to empower patients as well, to make them feel safe, to make them feel like they have some control and autonomy, and that they have an extra voice there if something uncomfortable is happening for them. And so the chaperone really shouldn't be somebody that is directly reporting to you, because then first, they might not feel comfortable speaking up if they notice that you're doing something that might be uncomfortable to a patient. But we're also, again, taking away the patient's voice in that setting. So I'd encourage you just to be mindful of that. So that's all before the exam. And then also, I just want to say that during right before the exam as well, when we're doing drapes and gowns, we want to make sure they disrobe to the level of comfort, and making sure that you're only disrobing what's absolutely necessary and explaining why. And once you start the exam, again, just explain, 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 consent, consent, consent. So just make sure that you're explaining. I'd introduce the components when you're doing the exam. I'd make sure to stay within eyesight. So a lot of us were taught how to do thyroid exams, for instance, by coming from behind and holding the throat. I'd make sure to stand to the side. When you're listening to the lungs, make sure to stand to the side and respect some personal space. And when we're using our language by explaining what we're doing, what we want the patient to do, try to make sure it's simple and clinical and don't personalize, meaning try to avoid your. So you, like, if you say your body part, and also don't do directives or orders, which I notice that after a long day I do as well, where instead of saying, for instance, open your mouth, what you will do is say, because you have cold-like symptoms, I do recommend that I look in the back of your throat. Is that okay? And then allow them to open on their own. Don't use things like I'm going to feel. You say I'm going to examine, or don't say bed, use exam table. As much comfortable language as possible. And do frequent check-ins and try to be as efficient as possible. Try not to linger as much is what I would recommend. Now, I know a lot of people will have questions perhaps about these sensitive exams, of course, which a lot of people will think about in terms of trauma-informed care. And these are just some recommendations that I've learned over the years and I've read through my research as well. But for instance, when we have people in a position where we're going to be doing a genital exam, some things that we can think about is that actually people, or oftentimes when we're doing a genital exam, especially on those with cervices that we want to do, let's say a pap smear on, we often lay them flat, but then they can't see us with the sheet in front. So you can actually put them more in a lithotomy position where you have a pillow so they can actually see you eye to eye, and we can still perform the necessary exam. You also want to make sure that it's an absolutely necessary exam and that you want to take a risk of actually re-traumatizing the patient and what is the risk of not doing the exam. I think about this often when I'm going to be doing cervical cancer screening on my transmasculine patients or those who are on testosterone, that if it is going to be significantly distressing for them to do the exam, then I ask myself, well, you know what, is this necessary or not? And so I talk to the patients about the risks and benefits. And we talk about things like HPV self-swabs. If patients feel more comfortable with self-swab, that's great. Now, again, when people, again, are laying on the table and you're performing a sensitive exam, never push out the legs. I've noticed some learners do that where they will gently push, never push open. Don't ask to spread legs, just gentle touch and say, can you allow your legs to fall open? Use as small of a speculum, use as much lubricant as you possibly can. Also, don't order or tell people to relax. That doesn't necessarily help. Usually we say, well, I find ways for people to relax are by breathing, so to speak. And you can also offer a mirror as well. You can have the medical assistant hold a mirror if they prefer to watch what's happening. Some people don't. So these are all things you can do. I also have a lot of my patients hold their phones during exams so they can distract themselves or listen to music, whatever they want. And remember that adolescents can have anybody there that they wish, partner, guardian, etc., to hold their hand, to be a support. That's absolutely fine. If at any point there's any discomfort or they say stop, we stop. You make sure to keep calm, no quick movements, offer water, consider stepping out. Again, anytime somebody is uncomfortable, stop. And so that's some tidbits, again, some words of wisdom from things that I've learned. And then after the exam, please make sure to step out, allow them some time to dress. I should have said this earlier, as a primary care doc, sometimes we'll have our medical assistants undress people if we know, let's say they're going to get a pap smear. But just remember that it's very uncomfortable for people to talk to physicians when they're already undressed, so I would wait. And then discuss the results and then ask them if they have any questions about the exam. And also I would just say for the clinical language too, to avoid jargon, and I also avoid using the term specific aspects, especially with my transgender non-binary patients. I don't say, I'm going to look at your vagina, for instance, because some people do not associate with that part of their body or don't want that discussed. So again, I just want to bring up some things to be mindful of, and this takes practice, but I think this is the first step, is being mindful about this. So those are some of my tips and my recommendations for exam, and I think we do have some time for questions, I hope.
Yes, thank you so much. People are writing into the chat, wow, so many people don't do this. This is great sensitive exam tips for more than just adolescents, and there are definitely some gems of wisdom that I heard too, that things like exam table versus bed, just those little trauma reminders, as Dr. Gibson was saying, that can be avoided if we just think about it in advance. Are there any questions that folks have. We have about 5 minutes now for questions if folks would like to ask anything. And folks are asking, are we going to have access to this recording? Definitely. So we'll have a recording of Dr. Gibson's session as well as the sessions that we're having now.
Can you talk a little bit about weighing patients and consent around gathering weight and how that would fit into a trauma-informed approach?
Absolutely, absolutely. And so I have to say too that I wish I could shadow my medical assistants and see what their language is around it, because I haven't watched my medical assistants prior to weighing individuals. And so of course, you know, individuals should be able to consent or dissent when they are being weighed. And so I think unless that we absolutely need it for a particular reason, like for instance, with really little folks that we may need something specific for a medication for weight-based, I was going to say, I think that absolutely within our, you know, any of the providers here too can make sure to shadow their medical assistants or talk to their clinic leadership about what your process is as the patient's being roomed, because of course, if a patient does not want that to happen, they should be able to provide consent. It should be a consent-based process. That's a great question that I haven't given a ton of thought to, but again, I think that it should be unless it's absolutely necessary for, you know, again, for any kind of medication or discussion that's needed.
Thanks.
If anybody has any thoughts about this too, obviously I am not the only person here with experience in this. So if anybody else has a clinic, you know, a clinic policy, please feel free to share.
Yes, please do. The next question, I actually had the same question, so I'm glad someone asked this. You mentioned that for transmasculine patients, you wouldn't label the vagina. What sort of words would you use instead if you're doing, for instance, a pap smear and explaining the steps that you're taking along the way?
Yeah, and this is specific to each patient too. Some do not feel uncomfortable at all with speaking about, let's say, cervix, or often I say if there's a body part present that we have a cancer screening for, I do recommend screening for it, and these are the options. Instead of actually pointing out specific body parts. And again, please feel free. I know there's a lot of people here with LGBTQ health experience as well, that usually when I'm doing the, so that's how I introduce why or why not I am doing the pap smear. Then when I'm actually doing it myself, I'm not really pointing exactly out the parts that I'm doing. I usually say, okay, exactly like I'm doing for every other human. This is my touch. This is where you're going to feel the speculum. Are you doing okay? Is it okay if I start to insert the speculum, et cetera, and make sure I'm getting consent? And then at any time there's discomfort that I stop. And just some tips for people who are on testosterone too. Of course, there's always discussion about the risk of retrauma versus doing the pap smear itself and the HPV self-swab. But you can also use pediatric speculum, lubricant, and then also you can give them some topical estrogen in the area for about a week before the pap smear, because people hear estrogen, they go, oh no, I don't want estrogen. Of course, that doesn't align with who I am. But it doesn't have a lot of systemic absorption, and it helps to make the area a bit softer and more comfortable before the exam. So those are some ways, but again, this is really patient specific and centered, because some aren't bothered by that at all.
Thank you. Yeah, and someone else is mentioning in the chat that when a speculum exam is indicated, they found that having the patient tell the clinician when it is okay to advance the speculum a few millimeters at a time can be a helpful option too.
And I'd also suggest that within your documentation, if somebody required a certain size speculum, to make sure to document that so that a future physician or yourself doesn't make the similar mistake of using something that would make them uncomfortable.
Great. And then a couple of more comments about being weighed. So one person mentioned, you know, maybe MA or whomever else could ask, is it okay taking your weight today? Instead of saying, we're taking your weight today. And then someone else commented that as identifying as a fat person, that they've never felt empowered to say no to being weighed. And so even being asked can feel hard. And so the recommendation might be literally just skip it unless it's totally necessary, and that could really improve folks' experience. So thanks for those comments, everyone. So someone else is asking, Premarin, I think I'm pronouncing that right, is expensive and often not covered for teens. Do you have a good way to get it to them without samples or other resources?
That's a great question. I am not sure if I do. I don't know if anybody else in the group has any recommendations for how to make sure we can get some topical estrogen or perhaps an estrogen tablet. Anything that we can do to help the comfort in that area. If anybody has found any helpful resources.
Nothing's coming through at the moment, but hopefully folks can continue to monitor the chat as time goes on if anyone has any resources.
And I can also research that as well to see if my colleagues at the Corner Health Center, if there's a way that they recommend doing that as well, especially if it's not covered or if it's expensive. And I can get back to Jenny or someone at IHI to share as well.
Thank you so much. Sounds like we'll be having lots of follow-up resources for folks after today too. So, well, thank you so much. We'll move on to our next presenter in this session, and we'll sort of structure it the same way. We'll have about 15 minutes of presentation and 5 minutes for questions. So thank you so much. I know folks found this really, really helpful. So next is back to Amanda.
All right, I'm going to go ahead and share my screen. This is the part I'm nervous about. Tell me when it's okay. Is it up?
Not yet.
Ah. Still not up?
No.
It's just telling me it is.
There it goes. Yep, you were just a little bit delayed on my end.
Dropped it. Okay.
There you go. Yep.
Okay. Fantastic. Good. Okay, so I'm going to talk a little bit about the employee part of trauma-informed care. And I will say that, so I'm from Outside In, as we've said before, and I just wanted to point out, Outside In is a federally qualified health center, but we also have transition age youth services. And so that's 18 to 25-year-olds who have experienced or are currently experiencing homelessness. So we work with a lot of people who have experienced chronic and complex trauma. And while I'm not going to specifically talk about the adolescent lens, that is always the lens I'm using, because that's my population that I've worked with my whole career. And so we say in trauma-informed care that part of it is about making the system trauma-informed for employees, which I think it can be very vague sometimes. And what exactly does that mean? And we always hear people say you have to have a good self-care practice for a career in the helping professions. I've heard people compare it to, if you're going to have a long career, it's like running a marathon. You have to have your strategies in place. And when we look at 2020, I would say, if we're going to stick with the running metaphor, 2020 has been like one of those obstacle course marathons where you like crawl through the mud and have to go up over the wall, and things keep happening. And so if you're like me, probably a lot of your self-care strategies are failing right now. And it can be really hard. So we're going to look at a little bit some concepts in the context of 2020. And so I'm putting up a slide here from Sandra Bloom with the sanctuary model that shows the concept of parallel process. And this is something that I think about all the time, and to be honest, sometimes struggle to try to explain. But it feels like one of those lenses that once you attach to it, you see it everywhere. And I do like this graphic because I think what it shows is all of these compounding systems that impact each other and that are related to each other. And you can see from the way that this diagram's drawn, all of these systems end up compounding down onto the client. And I would say that the staff and administration get squeezed in the meantime by that setup. Parallel process, by definition, it's talking about a dynamic when two or more systems that have relationships to each other, they can tend to develop similar affects or cognitions or even behaviors. So One example of this is at times when I've worked on teams where people started to get really burnt out, you can start to see that system, that team system, almost act like it has PTSD itself. I don't know if anyone's had that experience of being like, I could actually diagnose this team. So some of the stuff I would see is like they might have a negativity bias. They're having a hard time taking in anything good. Avoidance of trauma reminders, which in some cases might be our clients. You might start to see diffuse or strict boundaries. And one of the concepts within parallel process is that if you can fix one system, it might start to shift the adjacent systems. So I tend to, if I'm looking at the organization and feeling like it's looking pretty toxic or burnt out, I might turn to my team and work on my team to see if that shifts the dynamic. When we're talking about 2020 specifically, I think that we might start to feel like there's 400 things going on that make it hard to continue to do our work or to stay focused on our work. And I would say a lot of the things that are really overwhelming are outside of our control, and are maybe happening more on that darker purple, societal level. So you can start to have confusing feelings. And so one thing that we might be seeing, or that I'm seeing, is that some of the themes, some of the emotions that go with all these clouds that are popping up on the screen might start showing up on your team or in your organization. You might start to see a lot of anxiety around safety, and there are legitimate concerns about safety right now. You might start to see a lot of themes related around fear, injustice, mistrust. It can get confusing, and sometimes we can feel like we don't know where that emotion's coming from. So is my boss behaving differently, or am I mad at the world, or both? Maybe my boss is behaving differently, and maybe some of the reason that I'm having a hard time with my boss is because I'm really sick of people who are in charge. Is this new work role oppressive, or am I just stressed out about the Supreme Court? And so as we deal with these things, we might find ourselves putting feelings from one system onto another system. And that makes sense because we all act within our sphere of influence. So if we don't have power in one sphere, I feel like I don't know how to have an impact on the way that our administration is handling the pandemic, for instance. But I might have a lot of energy around how my organization's handling that. And if I'm feeling enraged at the way the federal government's doing it, I might also have a lot of energy coming at the organization around that. And that makes sense. And for that reason of the sphere of influence, we might also see our clients coming at us with a lot of emotion around all of these things going on right now. And it might be that our relationship's a place where it's safe to explore some of that feeling. I have the word disproportionate impact in the middle here because I want to stress that all of these crises happening have a disproportionate impact on our clients and our staff. And what is happening is our body, a lot of the stress is happening in the lizard part of our brain, or the reptilian brain. This is the precognitive part where we aren't really thinking through things, we're just feeling them. That's where our fight, flight, and freeze part comes out. And we might be living primarily in an alerted sense, more so than usual. A few weeks ago, we had really bad wildfires here in Portland, and the air quality index was toxic and harmful. And they were saying, don't go outside, don't breathe too deeply, don't move too much. And in the world of trauma-informed care, we're always saying move, breathe, drink water, that helps to metabolize trauma. And we're always kind of like saying that mantra to each other and to our clients. But when you're being asked not to move too much and not to breathe too deeply, we're like, drink water. But I was aware of how we're all trying to show up to work, and we're working with folks who in some cases are sleeping outside in this smoky air, and we can't breathe ourselves. And I had some staff say to me at the end of that week, like, I'm really sorry, I didn't feel like I was very efficient this week. I didn't feel like I got a lot done, which just broke my heart because of course you didn't. You couldn't breathe. And so this is the piece of, these are some little tips for things that we can do to kind of help ground ourselves, help just some lenses to consider. So we've practiced some grounding and mindfulness today. Connecting with your body and where you are feeling things in your body is really important to knowing ourselves and knowing how we're being impacted, but also just kind of sensing where that trauma is coming up in our own body. And that's also the move, breathe, drink water part. Challenging thoughts and assumptions, I think, is a really important piece to consider. Am I actually unsafe in this moment, or is my body just sending me that message? So we might have every impulse inside of our body saying, you know, you got to run or you're not safe. And it might not be, you might not actually be at risk. I think that is an extremely important one to consider also when we're looking at implicit bias. We might be interacting with someone that, you know, we've gotten messages throughout our life is dangerous. And so your body might be saying, I'm in danger, when in fact, you're not in danger. And so I think it's really important to always kind of be checking back in at the reality. Self-validation, this is my whole point of what I'm trying to talk about here, is we have to validate ourselves and we have to validate the context in which we're working. And this doesn't have to be our most productive year. It's okay. And then radical acceptance. That's really opening our eyes and seeing what is. It doesn't mean we have to like it, but if we can't accept what's actually happening, we're going to have a really hard time dealing with it and being effective in dealing with it. And then I want to touch briefly on vicarious resiliency. This is the good part of the work we do. This is probably why we all chose our careers. You know, the concept of vicarious resilience is to it's the positive effects of the helping professionals when we witness healing and recovery. And the idea of vicarious resiliency is to lessen the negative impact of what we're experiencing and to strengthen the positive impact. And Dr. Savitny put out 3 lenses to consider when looking at building up vicarious resiliency. And the first one's finding meaning, and that's tapping into your values. Why did I do this job? Why am I here? I know that when I'm seeing my team really kind of burnt out or having a hard time, I will often do a question around like, how did you feel when you first got this job? Or why did you want to work for this team? And it can really help people kind of like build up some of that resiliency. Challenging negativity, it's all around us and it's very easy to get stuck to it. And our brains are built to pick up negative stimuli. Rick Hansen talks about how, you know, our brains evolved to pick out negative stimuli that keeps you alive if you know what your dangers are. And he says our brains are like Teflon for positive input and like Velcro for negative. So we are built to find the negative, and we have to train ourselves to find positivity. And so a lot of times with team meetings, we'll start the meeting by asking like, what's something positive that happened in your professional life this week? And that's just sort of training our brains to become sticky for the positive stimuli. And then the third one is building community. And that's connecting with people who have similar values to you. It's, you know, seeking out those work support people who are maybe help you feel positive about the work you're doing. And this is the reason, actually, the big reason why I invited Jasmine to join us next. Jasmine, my coworker, she, about 4 years ago when things got real tough in the world, decided one of her coping skills was going to be to build a community. And so she started this event called Telltale, which is a monthly curated storytelling event. And it brings people together. It challenges people to get vulnerable and take a risk. Actually take no shit. That's her line. And I went to her event a couple weeks ago, and she did this piece about finding joy. And I was putting this together, and I was like, okay, you got to come share this with folks. So I'm going to turn it over to Jasmine, who's going to share with us her piece about joy.
Hey everybody, thanks for having me. I'm going to share this piece with you. All right. They want you to feel guilty. They want you to feel it in the pit of your stomach and in the back of your throat. We thought we needed comfort, but that isn't enough. Comfort is the minimum. Late at night, let all the grief bloom up, but by morning, we need joy. They're gonna try and steal it because joyless people are easy to convince, easy to fool, but we aren't fools, so let's not be foolish. They want you to feel hopeless, which we are already so good at. They want you to feel heavy and forlorn. It makes it easier, and we cannot make it easier on them. When people were polled about their guilty pleasures, people mentioned salted caramel chocolates, cheap hot dogs, and Stouffer's mac and cheese, because we're supposed to worry about counting calories to stay small even now. And they want you to be embarrassed, to walk around hungry all the time. They want your shame to grow and flourish while you edit your emails for tone and too many exclamation points. They want you to wear uncomfortable shoes and clothes with no pockets. They want you to hate your body, your job, your gender, your bank account, your partner, your apartment, your kids, your future. It's lucrative. It's money directly into their pockets. Hopelessness is contagious, and skepticism is ugly. They say trust the system, but the system is built on whiteness and apathy, and oh man, they love apathy. Your joy is a wild animal holding its breath. And when people were polled about their guilty pleasures, people said reality TV, $20 jars of face cream, and peanut butter and jelly sandwiches with top ramen and a pickle and tortilla chips on the side, which is really strangely specific, but whatever, because we're supposed to be better than that, but being better is really exhausting. Your joy can lower your blood pressure, slow your heart rate, improve your immune system, make you more resilient to pain, let you sleep better, live longer, increase energy, heal faster, absorb more nutrients, and stave off heart disease. Your joy can save you. Your joy is everything. When polled, people feel guilty about pedicures, that new Taylor Swift thing, and Ariana Grande records, because we aren't allowed to feel good about anything, really. And your lungs are right to feel belabored. Your awful stiff-armed anxiety really makes sense. It is reasonable that your heart feels tender and taken for granted lately. Your joy is an emergency. Is there anything they won't try and ruin for us? Your joy is a religion. You should be praying to the church of it. What are we supposed to do with our hands? These things that like jitter and clench, knuckles crack, fingers hold a pen that won't make words. They're jammed in pockets for safekeeping. You miss singing in bars in the summer with your finger around slit glasses trying to think of smart things to say. Why is joy reserved for lights off, closed doors, and eating fast over the sink? They say burn it down, but I don't know what it is. The system isn't a building, and they'll just put it in some other building somewhere else. They want your joy to be endangered. I want your joy to crush everything they try and build. No justice, no peace. And when polled, people feel guilty about watching Degrassi, Dawson's Creek, and Friends because we can't let our brains escape a little bit without feeling guilty. And they're not going to let you keep your joy easily. They're cowards. They are craven. We aren't allowed to have any heroes because everyone is flawed. You should be a weapon. How can we all be weapons? I want to be a weapon. When polled about guilty pleasures, people feel guilty about tostadas without any vegetables, long showers that use too much water, and Cheetos. And man, I really love some Cheetos. What's your joy? How do you protect it when they try and choke it out? They're so good at being the bad guys. When do we get to be conniving? When do we get to break the rules to win? When can we be just villainous to get what we want? When can we operationalize this anger? When polled, people feel guilty about young adult novels with vampires in them, smartphone games, and dating shows. We let people steal our joy all the time. Your joy is too small for this situation. You don't have to feel guilty when you feel good. You don't have to spend every moment in the pursuit of perfection. You don't have to produce or self-improve. Your life's work wasn't meant to be work. When polled about their guilty pleasures, people said White Claw, Top Ramen, and American cheese craft singles. We all get comfort somehow. They want to burn us for our joy. History repeats itself. They want to keep us as small as they can. We got to vote as one tool of many, but it's clearly not enough. We're not playing the same game. Eat the rich, burn it down, whatever it is, but what other tools do we have? Lately, I've been waking up with a feeling I can finally name as fear. And it's there in the morning before my eyes open and rolls back in when the night comes. It tastes like pennies in my mouth and electricity in my chest. Your joy is linked to hope, and hope feels dangerous. Hope can be taken away. Hope feels like a joke. But maybe joy can be weaponized. So here's my prayer. Our joy should be obscene. Our joy should be offensive in size. Our joy should be grand and wet and unchristian-like. It should be irreverent and endless and rooted deeply in the ground where they said no joy could possibly ever grow again. Our joy should be so thick it chokes them out. We should be an invasive species. Let's make them angry. Your joy should echo into all the empty spaces and shake the land that you stand on. They won't let you have it easily. I don't know what your joy looks like or where it's going to come from. Comfort is not enough now. So let's pray to the joy we have. Amen.
Amazing. Thank you so much. So I think we have about 1 minute for questions or reflections in the chat. Jasmine, I'll say that someone commented that they were snapping through the entire time you were speaking, and I wanted to echo that too. Editing my exclamation points in my emails is a regular practice for me, so that really resonated amongst other things. Let's see if there's any questions. Mostly folks are saying awesome, snap, thank you, so much truth, authenticity, powerful, wow, yay, loved it. So all of the above. Thank you so much. Any final words, Amanda or Jasmine, before we sort of transition to our
No, thank you for having us. And yeah, I think we said it all.
I think you did too.
I will say that my show is monthly, so if people want to come see me read other stuff, and other people from across the country also read stuff, which sometimes is vulnerable and heartfelt like that, and sometimes it's silly comedic stuff and anything in between. It's telltalepdx.com for tickets, and it's $7 suggested tickets, but everybody gets in for free if they can't afford it. So I would love to see anybody stop by if you want to see it. Thank you.
Thanks, Jasmine. I just wanted to mention and chime in also that we are sharing on our event page the links as well that we've just been mentioning. And Jasmine, someone asked if there's a text version of the piece that you just read, if you're willing to share that. I'm not sure if you feel comfortable with sharing the written version.
Sure. Yeah, people want to like email me through the website. I can just email a copy to them.
That's wonderful. Thank you so much. The other thing that we're going to do, I know that our marketing folks are planning on doing some amplifying and shout outs on our social media as well, so that if you follow AHI, there's going to be more information there too. So thanks for all the work you're doing for our community.
Thanks so much. And next we're going to have Alex.
Great. Hi, everybody. Nice to be with you all. I've thoroughly enjoyed the presentation so far, and I am going to switch it up and go old school with slides, believe it or not. And this may be a more buttoned up and stuffier package, but hopefully a radical heart in there somewhere. And here we go. I'm going to focus on addressing trauma among transgender and gender diverse adolescents. Specifically, this is something that was already mentioned and focused on a fair bit by our first speaker. This will have more of a mental health angle, and I look forward to hopefully some discussion with you all as well. I'm going to start by outlining something many of you who do a lot of work with gender and sexual minority adolescents may already be familiar with, which is a minority stress framework. This was initially developed as a sexual minority stress framework for sexual minority folks to understand health disparities and inequities that exist in clinical care research, policy work, and in recent years increasingly has been applied for work with gender minority populations, transgender and gender diverse folks. The idea in the gender minority stress framework is that trans and gender diverse youth developmentally experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately at a much higher prevalence than the general population. And the FBI has reported in recent years that the population with the highest incidence of hate crimes in the US is African-American transgender women or trans feminine youth. So this is the horrific reality many people are living with, particularly in Black and Latinx trans and gender diverse communities. For many people, this sort of chronic external stigma-related stress, as we refer to it, can lead to disruptions in certain general psychological processes like coping skills, emotional regulation, interpersonal functioning, having beliefs or cognitive structures that aren't super adaptive, like believing it's never going to get better, nobody can be trusted, no one will ever love me, which is adaptive in the moment. That's how trauma works, right? If you have a physically inescapable stressor, you may dissociate and do so to avoid experiencing the emotional pain of it. That said, if at some point you don't process the experience cognitively, emotionally, you're going to fail to recover, as they say in the field, from the traumatic experience. And that's where we see post-traumatic stress symptoms develop, where two people may have the same experience and one person may have a predisposition or a diathesis for it and someone else may not. And all this external stigma-related stress over time can also lead to internal stigma-related stress, internalized transphobia, believing all the negative things society has to say about your gender identity, expecting rejection because you're so used to it, and identity concealment to prevent mistreatment and abuse. We think this is related to what we see in the research, which is a higher prevalence of certain behavioral health problems like depressive disorders, anxiety disorders, post-traumatic stress disorder, in some cases substance use disorders, as a way to cope with all this stigma-related stress, decreased self-care, decreased engagement in healthcare, and down the road a much higher prevalence of various physical health problems as well. This is the US Trans Survey that included about 28,000 trans and gender diverse adults across the country, including many people from Michigan. And the survey found that 10% of respondents reported a family member was violent towards them because of their gender identity. 8% were kicked out of the house because of their gender identity. Many experienced serious mistreatment in school, like being verbally harassed, physically attacked, sexually assaulted because they were trans or gender diverse. And 17% experienced such severe mistreatment in school that they had to leave before graduating. This is a study we published a year ago in the American Journal of Public Health, and this was using the trans survey that I mentioned nationally with 28,000 folks. And we looked at prevalence across the country, state by state, of efforts to change someone's gender identity from transgender to cisgender. This is colloquially referred to as conversion therapy. We don't call it therapy because that implies it's a legitimate therapeutic practice, which it is not, and there's no evidence for it. So we called them psychological attempts to change a person's gender identity. And here's a heat map of what we found across the country. You can see that there are certain trends in terms of where these efforts are more common. And we did this because there's an effort state by state to ban sexual orientation and gender identity conversion efforts for youth. And in several instances, the governor in the state will receive a bill that the state has passed to ban these efforts. And the governor will say, for example, well, these efforts don't happen in our state, so we don't need a ban. And then that'll thwart a ban on conversion efforts. That happened in Maine in 2018 as an example. It's still only less than half the states in the US that have these bans. And it's amazing how common this is. We found in our study that 13.5% of trans people in the country have been exposed to gender identity conversion efforts, and that almost 200,000, it was specifically 188,000 people in the country, we estimate, have been exposed to these efforts. Some more data from the US Trans Survey. Many respondents reported experiencing serious psychological distress in the previous month compared to about 5 times fewer in the general US population. 40% of respondents had a lifetime suicide attempt. That's much higher than for any other studied population in the US. And that risk of attempting suicide drops significantly when people are able to access gender-affirming medical care. So it's important to think about gender-affirming medical care as life-saving treatment for trans and gender diverse people. If we look at comparison with the general population and with cisgender sexual minority people, it's still a much higher prevalence of suicide attempts among gender minority folks. So it's not just the already very high prevalence of suicide attempts in one's lifetime that we see among cisgender sexual minority folks. It's a good 2 times higher than that. If we look at these data a little more closely, in the previous year, 48% of respondents had suicidal ideation, 24% had a suicide plan, 7% attempted suicide in the previous year. And of those who attempted, you can see 34% had their first attempt by age 13, 92% by age 25. So those of you working with adolescents are working with a critical age bracket where you can really save someone's life and fundamentally alter their life trajectory. This is a study we published a year ago in JAMA Psychiatry from the same large national data set, looking at the association between these conversion efforts and suicide attempts among trans and gender diverse folks. We found that lifetime exposure to gender identity conversion efforts was associated with more than double the odds of suicide attempts. And if exposure was before age 10 to conversion efforts, it was more than 4 times the odds of attempting suicide. And interestingly, there was no difference in risk of attempting suicide comparing exposure to conversion efforts by a religious advisor versus a secular type professional. Any effort to change the person's gender identity to cisgender was associated with increased risk. So it's not the religious component that's dangerous. This is a study we published at the beginning of 2020 on pubertal suppression for trans youth and risk of suicidal ideation. So this is access to gonadotropin-releasing hormone analogs, pubertal suppressants like Lupron, in 10 or stage 2 of puberty. That presses pause on puberty so that these youth don't start developing secondary sex characteristics that don't align with their gender identity, which can be very distressing. And at that age, unfortunately, we see a big increase in distress for many youth and increase in suicide risk. And we found that only 2.5% of respondents who desired pubertal suppression ever received it. And of those who received pubertal suppression, among them, we saw a much lower association with attempting suicide or suicidal ideation than we did among people who desired pubertal suppression but didn't access it. So being able to access pubertal suppression associated with lower lifetime suicidal ideation. This we published in January, and literally the next day, South Dakota's State House had a bill they put forward to criminalize gender-affirming medical care for adolescents. And that means like physicians going to jail or prescribers going to jail if they provide gender-affirming medical care. There have been 20 bills in 2020 at the state level in various forms to either criminalize gender-affirming medical care for adolescents, so like put clinicians in jail or prison, I should say, to either revoke medical licenses for people who prescribe, and attached to several of those were measures to report parents and guardians for child abuse for taking their kids for gender-affirming medical care. So this is real. This is like national battleground right now, and a lot of people just are confused about the trauma that comes from not being affirmed in your gender identity in adolescence. So kind of education you all can do in your communities, in your healthcare organizations, in your practices will go a very long way. This is another study we published looking at factors associated with higher PTSD severity among trans adults. Higher PTSD severity was associated with more everyday discrimination, having more reasons for which you attribute being discriminated against. So this is an intersectional phenomenon where if you report being discriminated against for your gender identity and your race and your socioeconomic status, that cumulatively was associated with more severe PTSD. Higher visual gender nonconformity, not blending in a binary way as girl or boy, or woman or man, associated with more severe PTSD. Unstable housing, which we know is unfortunately extremely common among trans and gender diverse adolescents. Lower PTSD severity associated with younger age, that may be because rapidly younger and younger cohorts are more and more accepting of trans and gender diverse people, or that older and older cohorts have more of a lifetime of accumulated discrimination. Transmasculine gender identity associated with lower PTSD severity, that may be because we live in a patriarchal society where people are more accepting of someone assigned female sex at birth who identifies as more masculine than someone assigned male sex at birth who identifies as more feminine. Medical gender affirmation, if you're able to access it, associated with lower PTSD severity. There are great evidence-based interventions for PTSD that we can tailor in a culturally responsive way based on a minority stress framework for trans and gender diverse adolescents, like cognitive processing therapy for PTSD, great evidence-based intervention, manualized protocol developed by Patty Resnick for survivors of sexual assault. Every VA in the country is required to have a CPT therapist, and over 98% of them do. This, among other things, focuses on education about post-traumatic stress, an impact statement to help understand how trauma influenced the person's beliefs about themselves, about other people, and the world around them in various domains, including power, safety, intimacy, control, and trust, for example. Identifying maladaptive thoughts that are called stuck points in this intervention about the trauma that perpetuate emotional distress. Decreasing avoidance and increasing resilient coping. It really conceptualizes post-traumatic stress disorder as a disorder of avoidance. and focuses on enhancing resilience. By the way, the impact statement can be oral. It doesn't have to be written, so there's no literacy requirement for this intervention. So how do we tailor this in a culturally responsive way for trans and gender diverse adolescents? We can focus on how gender identity specific stigma causes post-traumatic stress, can lead to avoidance, mistrust, hypervigilance, low self-esteem, how particularly younger people will attribute challenges in their life to personal failings rather than to minority stress, anti-trans stigma that may exist in society. So if we can help people correctly ascertain when stigma and minority stress are at play, that can be very empowering. Impact statement on how discrimination and victimization affect beliefs, expecting rejection, concealment needs, internalized transphobia, decreasing avoidance like isolation from trans and gender diverse community or medical care, and the impact minority stress can have on health behaviors and goals. Important to note, many people cope with stigma and minority stress in school and mistreatment in school by using substances, and cope with lack of access to gender affirming medical care by using substances as well. Large national studies have shown this. As clinicians, we can normalize the adverse impact of gender minority stress, help people attribute challenges in their life to transphobia and societal stigma, facilitate emotional awareness, regulation, and self-acceptance, empower assertive communication. For better or for worse, trans youth have to be advocates for themselves in healthcare and in life. So we do a lot of training to not engage in passive or aggressive communication, but effective assertive communication. Restructuring some of those minority stress cognitions, like it's never going to get better, nobody can be trusted, no one will ever love me. Validating unique strengths of trans and gender diverse people, right? This is a community that's overcome enormous obstacles, achieved greater and greater integration into the mainstream fabric of US society. We can help particularly trans and gender diverse youth feel connected to that strength of the broader community. That's very empowering. Fostering supportive relationships and community with other trans and gender diverse youth and with allies. And affirming healthy, rewarding expressions of gender. Our patients will be in the waiting room wearing clothing traditionally associated with their sex assigned at birth. They'll come back to the clinical area, change in the restroom. We'll do the session with them wearing a dress for the first time or exploring some form of gender expression process, what that's like. We'll then change in the restroom and walk out the waiting room in the health center that way. That's a great position of privilege we have to offer that safe space for gender identity, exploration, discovery, and affirmation. Important to note, we do need to make every effort to stabilize psychiatric problems that may be present, not because we think that the person's gender diversity is due to their psychiatric problems, but because psychiatric problems impede the very critical process of gender identity, exploration, discovery, and affirmation. And we don't affirm gender identity after treating psychiatric problems and wait until everything's in remission. We do it in parallel with at the same time as treating psychiatric problems. The World Professional Association for Transgender Health, Standards of Care 7, call for reasonably good control of physical and mental health problems, not remission, not being asymptomatic. We want to foster gender identity, exploration, discovery, and affirmation, present both medical and non-medical strategies for gender affirmation, include changing your name, your pronouns, changing official government-issued documentation, chest binding, genital tucking, and referrals as needed. It's really about informed consent and capacity to make medical decisions. Of course, we need to do a lot of family systems work, basically across the entire country. If legal parents and guardians don't consent to gender-affirming medical care, that youth, unfortunately, is not going to be able to access it. So a ton of effort within healthcare organizations needs to go towards family systems work and onboarding and educating the parents and guardians. We want to focus on internalized transphobia, reducing this, help improve body image, even while we're supporting body modifications. So people have realistic expectations for how masculinized or feminized they're going to be at the end of process, and particularly for youth, facilitating adjustment concretely through various domains: physical changes, psychological changes, changes in social dynamics, in sexual functioning or libido, fertility preservation, economic challenges, and even legal challenges that may emerge. Finally, I want to end on a note about resilience. It refers to the ability to bounce back or rise above adversity as an individual, family, community, or provider. Well beyond individual characteristics of hardiness, resilience includes the process using available resources to negotiate hardship and or consequences of adverse events. And SAMHSA has these fabulous resilience-oriented, strengths-oriented resilience building questions. So you include these in your interactions and sessions and practice with trans and gender diverse youth, or all youth really? What are some of the accomplishments that give you the most pride? What would you say are your strengths? How do you manage your stress today? What behaviors have helped you survive your traumatic experiences? What are some of the creative ways that you deal with painful feelings? What characteristics have helped you manage these experiences and challenges they've created in your lives? If we were to ask someone in your life, knew your history and experience to name 2 positive characteristics that help you survive, what would they be? How do you gain support today? And what does recovery look like for you? Thanks so much for your time. Please feel free to check out our educational resources, all available for free with continuing education credits at the National LGBTQIA+ Health Education Center, lgbtqihealtheducation.org, and you can email us at education@fenwayhealth.org.